most recent data from the maternal mortality review committees is very clear that 23% of maternal deaths were due to mental health. And when we think about it in the perinatal time period, so pregnancy and postpartum, that crisis becomes even more urgent because there's the transgenerational impact. And if we treat these illnesses, there's the potential to promote outcomes for generations to come as well. The other piece I'll add is that there's major inequities. We know that, we have a very hierarchical medical system in America that's increasingly becoming a capitalist medical system, and it creates hierarchical access to care whereby, if someone's not in a position to, for example, pay cash for an appointment or what have you, it's much harder to access care. And if someone can, it's extremely hard to access mental health care during any time period, particularly during the perinatal time period.
Welcome to Meeting of the Minds with Wobot Health. I'm your host, Chris Hemphill, and I'm joined today by our Chief Clinical Officer, Dr. Athena Robinson. Quick hello, Athena.
Hello, everyone. Nice to be here. Thanks for the invitation, Chris.
No problem at all. So to kick this off, the stigma that makes mothers and birthing people afraid to speak up on mental health challenges is a fatal stigma. Dr. Nancy Byatt, while presenting to the National Institution of Mental Health, the NIMH, shared that 1 in 5 people suffer from mental health and substance issues during their pregnancies, and that this is a leading cause of death right up there with infections. So anybody who's watching or listening, there's a reason you chose to go into this particular webinar, and anybody who's watching or listening to this knows that we're not going to sit idly by. We can't sit idly by as people deal with death and suffering that's preventable. So it's an honor that Dr. Nancy is joining us today, and we're going to go in deep on some important work that she's done. She's founded the Maternal Child Psychiatry Access Program, MCPAP and MCPAP, which provides resources for clinicians and birthing families to manage mental health during these critical moments. Her program serves as a national model right now, being adopted by nearly 30 states, and it's influenced legislation such as the Bringing Postpartum Depression Out of the Shadows Act. So Nancy has told me about her personal journey and about her learnings while leading this program, and we're going to go deep on the challenges that she's focused on solving. We're going to go deeper into her personal journey, how to drive that change in your own work, and some of the technical tools out there that may help with this extremely overly common brand of suffering. But to kick us off, Nancy, could you tell us, I've given some ideas on what people can take away from the webinar, but could you tell us what you're hoping, what drove you, that you're hoping that people get out of this conversation?
Sure, yeah, and thank you for inviting me. It's a pleasure to be here. So I would say three things I would hope people would get out of this today. One is recognizing how common and how prevalent and the negative impact that mental health and substance use disorders during this time period have. I would say the second piece is understanding that our systems, we really need to do a lot of work within our systems to equip our healthcare systems to be able to thoroughly address mental health and substance use disorders during pregnancy and the postpartum period. And I would say the third piece is recognizing that we have social and political determinants of health that drive negative outcomes. We have policies that can either mitigate inequities or that can perpetuate inequities, and sort of thinking about those different levels, so multi-level barriers and facilitators to thinking about perinatal mental health care.
Nancy, first of all, I want to thank you for bringing that up in the way that you did, and kind of expanding the thinking even around social determinants of health by introducing the term political determinants of health, because what you're framing up is an idea that medicine doesn't just begin with in-person care. It's a network of all these things, and creating the right type of environment that folks need to receive care. Athena, really curious your perspective. We were talking a little bit earlier about some of the things that you hope people get out of this, and would love for you to share that with the audience too.
Yeah, I think, there's so many wonderful things we can do as humans, but when you really sit back and look at what birthing people and mothers do, bringing a new life into the world is profoundly incredible. And it's so understandable that so many life roles, identities, physical and mental health can transition with that. And so I think that our ability to have conversations like this with experts like Nancy, to invite birthing people and mothers out to speak up against the stigma, to join with them as providers and bringing people together, to show people they're not alone, that it's understandable this is a massive change in your life, and that building that community and connections, as you were mentioning, Nancy, is imperative for all of us. It's been decades worth of community to try to get birthing people and mothers and women's health on the map, and we are making some steps little by little, thanks to the work of Nancy among others, but you're not alone. And the more that we talk about it, the more we can perhaps honor the fact that when people raise their hand and ask for help, we'll be there to actually get them connected to the help they need.
Appreciate that thought, Athena, as well. So the community building and the networking that you're talking about, honestly, we hope it happens here. As people comment, share stories and things like that, people say things that you like. Use this as this LinkedIn Live. Use it also as a networking opportunity with other people of like minds, because sometimes it can feel lonely fighting a fight for health equity. Use this network to your advantage, y'all. Now, I want to jump into this because when we talk about awareness, when we talk about the platform that this issue has, I'll admit, even on my own, I wasn't aware of the significance of the challenges around maternal mental health even 2 years ago before I started working with you, Athena. So Nancy, I would be curious if there's a way that you describe kind of the state of the union of what are the challenges with maternal mental health today?
Mm-hmm, mm-hmm. So it's 1 in 5, as you mentioned earlier. So 1 in 5 individuals will experience a mental health or substance use disorder. And unfortunately, they're also underdiagnosed, undertreated. So even if a woman or any perinatal individuals, many of whom do not identify as women, screen positive for depression, less than a quarter of them will even be able to access an initial mental health appointment. So they're common, they're undertreated, and we also know that they have a negative impact. So they impact the birth outcomes, they impact, healthcare maintenance during pregnancy, and we also know that they impact the relationship between the parent and the child. So common, undertreated, and having negative impact. And we also know that they are the leading cause of maternal mortality in the United States. The most recent data from the Maternal Mortality Review Committees is very clear that 23% of maternal deaths were due to mental health causes in the most recent Maternal Mortality Review Committee data. So they're also a leading cause of death. And so we really have an urgent public health issue in our country to address mental health and substance use disorders during this time period. We have obviously a mental health crisis broadly. I would actually say that we have a mental health emergency. I think we've been in a crisis for decades, and we didn't address the crisis, so now it's an emergency. That's the way I think about it. And when we think about it in the perinatal time period, so pregnancy and postpartum, that crisis becomes even more urgent because there's the transgenerational impact. And if we treat these illnesses, there's the potential to promote outcomes for generations to come as well. So I would say that's the sort of urgency around this. And the other piece I'll add is that there's major inequities. We know that we have a very hierarchical medical system in America that's increasingly becoming a capitalist medical system, and it creates hierarchical access to care whereby, if someone's not in a position to, for example, pay cash for an appointment or what have you, it's much harder to access care. And that is a very privileged select group that could pay cash. And if someone can, it's extremely hard to access mental health care during any time period, particularly during the perinatal time period.
But thank you for that description too. And it just sounds like we need to get to a place where if we were to ask anybody, like randomly, hey, what is the leading cause of maternal death? I just imagine that most people wouldn't have that answer top of mind, that it is mental health. Mm-hmm. So getting to that, you also mentioned you mentioned healthcare inequities and like the the model that we introduced, like where there's hierarchical access to care. Part of my role is also, I'm a fellow of the NYU McSilver Institute for Poverty Policy Research, and one of our key focuses is on Black maternal health. Are these the types of intersections, or what types of intersections are you seeing from a health equity perspective when it comes to maternal mental health?
So absolutely. So in general, there's marginalization for sort of by gender, right? So a part of what motivated me early on was to get into women's healthcare and perinatal healthcare, was I saw that there was this huge gap where pregnant and postpartum individuals were not getting the same kind of care. Just to give a concrete example, many psychiatrists, I was seeing that I'd see a patient and the psychiatrist might say, oh, well, come back when you're not pregnant and then I can treat you, which is absurd, right? And then, they were sort of falling in this gap where, the mental health professionals weren't necessarily comfortable treating them, didn't have the training. It wasn't required part of psychiatric residency training to see a pregnant person. People were afraid. They didn't want to do anything bad to the baby. And so people sometimes wouldn't necessarily feel comfortable treating the parent or the pregnant individual. And then you have a situation also. So that's sort of been an area where we've seen marginalization from a standpoint of, there's less data on women's health in general. The studies have often not always historically included women. So there's that piece. And then you add on oppression due to other forms of oppression like racism and other things, right? And so we definitely see there's the sort of marginalization you can have due to gender. And then that also, we can see additional marginalization due to someone's pregnant or postpartum due to the barriers. And then you can have marginalization due to racism and other forms of oppression. So what we certainly see is it's hard for pregnant and postpartum individuals to access care. And then that gets amplified if someone, for example, is from a marginalized group due to racism. So what we see, for example, from a racial perspective is like Black individuals and other individuals who have been oppressed due to racism, we see that there's elevated rates of illness, of screening positive. However, there's lower treatment rates. And interestingly, our group, we actually did a study in on our randomized controlled trials. And we looked at, because you often hear this narrative that, and certainly when I either read papers or I'm listening to people talking about some of these barriers, you hear people saying, well, people aren't participating in treatment. So we actually looked at the care pathway, and we looked at from screening to being referred to treatment initiation and follow-up. What are we seeing as far as racial disparities? What we actually found was that referral rates were lower in this study by white non-Hispanic individuals were referred more often than individuals who were racialized. But we saw that the treatment and follow-up rates were actually the same, if not more, among the racialized individuals. So that narrative that's sort of like where you often hear this narrative where they're not participating in treatment was actually not right. It was actually at the point of the referral. So we see that there's challenges with access, and what we're seeing is that it's actually happening when we think about, for example, the workflow of a practice, that referral rates can be lower, and this is often based on whether the insurance somebody has, but also based on biases within our system. So we're seeing major inequities as it relates to that, and it gets amplified because of all these different kinds of inequities that we see.
Wow. So when you see these kinds of challenges, and often often what happens is people who have been oppressed or been marginalized their entire lives, they can fall into a mentality where, hey, when we're there's a certain type of change that we know that we need, there's certain things that we know we need to do, but it's really terrifying a lot of time to rock the boat and there's a fear of reprisal for speaking up in certain types of ways. So when I think about you working and founding MCPAP and or am I saying that right? Am I abbreviating that? Okay.
Yeah, it's a challenge. It can be a challenging acronym. It's people pronounce it MCPAP. Yeah, the Massachusetts
MCPAP.
Child Psychiatry Access Program for moms. So it's MCPAP for
Okay.
moms. There's actually one for kids that ours was built off of, and this is the one for moms. So it's for perinatal individuals.
Okay, got it. So MCPAP. I'll say MCPAP from now on. But it's extremely difficult to set up programs like this because it's hard to know that you're going up against a multi-trillion-dollar industry and institution. So I'm curious about what inspired you to go the other way and fight the good fight to found MCPAP and start working with these populations.
Yeah, I appreciate that question. So I grew up acutely aware of the importance of maternal mental health because I grew up seeing my mother actually struggle with the disrupted bonding or attachment she had with her own mother. When my mother was a baby, this was in the 50s, and my grandmother had some sort of we don't understand, likely bipolar disorder, psychiatric illness, and she couldn't tolerate my mother's presence. So they went to their family physician, and their family physician told them to put an ad in the paper for someone to take my mom. So my mom was sent to go live in a family that she'd never met for 6 months during her first year of life. And it was the people who answered the ad to the paper. And then she went back to her biological family at 11 months. And from what I could tell, my grandmother was profoundly depressed throughout my mother's childhood and really just wasn't available to my mother. So when I grew up, I knew my mom was struggling through this. My mother was, it was just obvious that she was struggling with this disrupted bonding or attachment. It sort of created this transgenerational trauma in our family that's impacted me and my children and so forth. So I became a psychiatrist partly because I was seeing all of these mental health challenges as I grew up. No surprise, I became a perinatal psychiatrist because I saw what my mom struggled with. And then I remember I was in the clinic, I was seeing an individual who was pregnant. I was seeing patients as a co-located psychiatrist in an OB clinic, a Brigham and Women's, where I was a fellow, and in fellowship training. And this individual presented, and she described, she was in her second pregnancy, and she described her experience in her first pregnancy. And she described to me that when the baby was born, it hit her, she described it hitting her like a ton of bricks. The baby felt like an alien to her. And she ultimately felt like she was in a black hole for that baby's first year of life. Probably not dissimilar to what happened with my grandmother, right? And what struck me about it, and she came in her second pregnancy saying, I don't want to have this experience again. Can you please help me so this doesn't happen again? And there was a few things that struck me about her. One was the profound impact it had. She really described not feeling that she could be there and really not bonding with her baby in the way that she had been hoping for or expecting to. So the profound impact was one piece that struck me. The second piece that struck me was that she was seen in pregnancy, postpartum, by OBs, by pediatric professionals. Nobody ever asked her about depression. Nobody ever talked to her about it. There was so many missed opportunities to address mental health. And the third piece was that she had absolutely no idea that she even had depression until 2 years later when she began to come out of it. And it really struck me that there's a real missed opportunity to be addressing mental health during pregnancy and the postpartum period. And at that same time, I was a psychiatrist seeing pregnant and postpartum individuals. I had a really long wait list to see me. I thought, what I'm doing is not that hard. I can teach others to do this. There's got to be a better way, because it was taking people months to get in to see me. And the OBs were also down the hall saying, like, Nancy, I don't know what to do. Can you help me with this patient? And they wanted to help. They didn't know what to do. So that really led us to think about, there's got to be a better way. There has to be a way to be able to integrate mental health care into perinatal care, because it's twice as common. Depression in pregnancy is twice as common as diabetes. We would never not screen for diabetes in pregnancy. And so it really led me to think about what could the model of care be. We then went and we did focus groups with individuals with lived experience of mood and anxiety disorders and with OB professionals, and we asked them, how can we help address mental health? And what we heard from them is they wanted a lifeline. The individuals' lived experience told us, we want our OB to ask us about this. We want them to address mental health. We want this to be part of our perinatal care. And we heard from the providers that they didn't know what to do, and they wanted someone they could call to get help. So that was what led us to create the model, the MCPAP for Moms, the Massachusetts Child Psychiatry Access Program for Moms, really is a way to increase access to perinatal mental health care by building the capacity of perinatal care professionals to address this themselves. And we do that through telephone consultations, so OB can call, they can ask us questions, and we can help hold their hand to do something that they weren't trained to do. It'd be like if I was all of a sudden treating high blood pressure, I would need training. I'd need to be able to call a primary care and ask, how do I do this? I wouldn't know either. And we did trainings, and also we can help link individuals with resources in the community. And we can see people for those one-time consultations as well. So it was really born out of seeing the gap in care based on that were deeply rooted in my own personal experiences as well, and saying there has to be a better way. And I think the other piece is seeing that, mental health care has to be on par with physical care, and to value mental health care as part of that, we need to be able to integrate it into these other care settings where pregnant and postpartum individuals are already being seen for care.
There's so much of that I love, Chris, if I can just take a minute and wiggle in what you just said, Nancy. That's so beautiful. I think one thing I hear, if I may, is like meeting these birthing persons where they're at. It takes a minute to raise your hand and say, you know what, I'm having a hard time with my baby and I would really like some help, or this happened to me during my last pregnancy. I don't want it to happen again. Please help. And noticing that, and then zooming out to where they are already at, bringing in the providers, providing them with those connections and that training. You're not revamping the whole system. You're building it up in this really great way to listen to both ends of it. The clinicians want to help. That's why they're in those jobs. They want to be there for these people in their moments of bringing this life into the world, and listening to that, and also not having these new moms or birthing people have to create more time and space in their day or in their sense of overwhelm when they may not be able to do that, right? Really getting them to where they need to be in that moment. So just kudos to you. I know I'm just rephrasing what you just said, but I hear you listening to that ecosystem in a way that's really worth sort of wiggling in for a moment.
And I think part of it is that I saw that there was a relationship between perinatal individuals and whether it's a pediatric professional or B professionals that wasn't harnessed to be able to address mental health, right? They're seeing these individuals, and it was a place where there was a missed opportunity to be able to, like you said, meet those individuals where they're at and integrate it into the care where they already are. Because most people don't actually want to necessarily go to the mental health clinic down the street. They'd rather have it be part of their OB care, because we address asthma, we address lots of other things as part of OB care, and often people prefer that.
So one thing that's interesting, it just came up in the audience because we're thinking through these clinician experiences, and in the audience, Alicia Harris asks for Dr. Byatt, what are your thoughts on having trained perinatal mental health clinicians that are embedded in OB offices?
Yeah, it's a great question. So I would say that I would love to see first, I would love to see a trained perinatal mental health clinician in every office in America throughout the country. That is fantastic. I would love to see it everywhere. Unfortunately, it's not realistic, and it probably won't happen any of our lifetimes, while it's wonderful. And I actually, interestingly, was a co-located mental health clinician for a long time before I started MCPAP for Moms. And what I saw was that I couldn't see everybody that needed to see me. I couldn't do it. I just didn't have the availability, right? And if all the individuals that actually are experiencing a mental health or substance use disorder during this time are actually screened, and that is uncovered during that process, there's absolutely no way we don't have enough clinicians to see them, whether it's in a co-located in an OB clinic or not. So it really gets to needing to build capacity for people. Like, you don't have to be a therapist to be therapeutic. And so thinking about how can we integrate these other therapeutic interventions and also assessments and treatment into settings where people are already being seen, and scaling those types of things, because while that is lovely, and I would wish we could have in all of them, it's challenging because there's funding challenges with it, but even if there wasn't funding challenges, it would be very hard to scale that throughout the country. So we need to think of other ways in addition to that, not to replace that, because that is so important. There's also a need to find other more scalable ways to do it in addition to those co-located models of care.
That's an important reality to bring up, is that we have what could be the ideal model, but when it comes to the amount of people available to deliver that and effectively integrate it, it's just very sad that we don't have on the one hand, it's sad that we don't have the people capacity to deliver it in that way, but I love the idea that, hey, well, let's come to the table with alternatives and different things that we can do to alleviate in the moment. And Speaking to that, we've been digging in deep on MCPAP, and I'm really thankful that you shared the story about your mother and your grandmother and that experience. And I'm curious after founding the program, if there are other patient stories or examples that you zoom in on as exemplars of what can happen when these kinds of services and tools are made available for that clinician-patient relationship.
Yeah, I would say that, one of the ways that I'll give a couple of examples of which I think exemplifies some of the challenges within our healthcare system, but also how these programs can help. So an example that we often actually see is where we will have an individual who's discharged, for example, from a psychiatric hospital, who's really quite ill and really needs ongoing care, and there's no one to treat them. So often when individuals are discharged, for example, from a psychiatric hospital, ideally they should all have a referral to a psychiatrist and a therapist and come out with a solid plan. Often that doesn't happen, primarily because there's no one to refer them to, and there's no availability, particularly if someone has public health insurance. So one of the things that we're often doing is helping OB/GYNs to treat individuals who have quite complicated illness and need ongoing care. So an example of this was, if someone's discharged from a hospital, an OB calls and says, we're discharged from the hospital, we're not sure what to do. They don't have a psychiatrist, they don't have a therapist. We see them and we help that clinician come up with a solid plan, and we can actually assess the patient and make recommendations regarding pharmacotherapy. We can also make recommendations, connect them with therapy in the community that the hospital wasn't able to do. We can't necessarily find them an ongoing psychiatrist, but interestingly, a lot of times the OBs, we've been amazed at what complicated care they're willing to provide when somebody has their back, like a lifeline, for example, like calling us and having us be holding their hand, helping them manage. Is that ideal? No. Should everyone that's discharged from a psychiatric hospital have a psychiatrist? Absolutely. But it's not the reality. And so we're often helping OBs to manage pretty complicated illness, which is honestly far beyond what I ever thought we would see. The reason I'm describing these cases is because I think it speaks to one, sort of some of the gaps in care, where even if someone's been acutely in a hospital, they still aren't necessarily referred, like they don't go home with outpatient treatment necessarily. And two, that when you have these capacity building mechanisms and you have someone to hold somebody's hand or build their capacity to provide care, I've been amazed at what mental health trained professionals are able to provide. So I'll stop there, but that's the sort of, one of the examples I think of because it exemplifies some of these points.
Geez, stop there, but like it was getting good. Like you were getting into that clinician responsiveness. But it just makes me immediately wonder, like we have this lifeline and people are delivering care in ways and in depth that you weren't expecting. What do you hear back from the clinicians? Like what's been the response and uptake? Like how did they respond to be able to integrate this into their care journeys?
It's interesting. So there's a continuum, right? There's people who are like, I was trained to be an OB. I don't want to do this. That's rare, though. It's really rare, and we see it less and less. ACOG, actually, the American College of OB/GYN, their guidelines that they just came out, I had the opportunity to serve as a consultant on the most recent clinical practice guidelines, and they clearly outlined that OBs are expected to assess, treat, manage mood and anxiety disorders. It's very clear. That is the standard of care. When we started doing this 10 years ago, it was not. So in the beginning, we would hear, well, you want us to do what and why? But that's not what we were trained to do. But then if we said, well, we can see them, we can help you figure it out, they'd say, okay, we'll do it. So there's been a continuum, and I would say that we've absolutely seen that change over time, that now I've been amazed at how they're willing to really provide mental health care because they know it's important. And I would say on the other end, it's now the standard of care, which makes it much easier because we are really there to help them meet the standard of care, which I think is really important. And a lot of times what we hear is, just give an example from a call I took recently from a, OB professional. They got off the phone or we were on the phone and they said, I have this person, this is what's going on. They said, I'm happy to do whatever you think, just tell me what to do. And in some cases, it's really complicated. And what they often say is like, I'll do whatever you think. If you could see her and tell me what to do, I'm happy to do it. Because they really recognize that it's that, or sometimes, waiting 3 to 6 months even for an appointment with a psychiatrist, which is unacceptable. It's unacceptable at any time period. It's particularly unacceptable if someone's pregnant or postpartum. So generally we hear that they're grateful And we hear that they're happy to do it with us holding their hand. That's what I generally would say that we hear from these professionals who are calling. Sometimes some resistance, but that decreases more and more over time. And once they start doing it and they practice it, they realize it's not as hard as they thought it was.
And builds on what maybe they're familiar with too, right, Nancy, in this notion of consultative practice within medicine. Like if ACOG is really clear about it, that part's not new. Like, how do I talk to another well-trained colleague or another source to optimize care delivery or to think outside of the box in this case, knowing that I might be the metaphorical quarterback for this patient's journey? How can I use this consultation here? And so I think that model of that can be really helpful for people to lean into too, because it's familiar.
And yeah, I'll add one more piece that I think it's really interesting, because I often use like diabetes as a parallel. And I would say the other thing is that we're seeing change in OB care. So if we think about sort of mental health care, right, and we think about diabetes, like if someone had diabetes in pregnancy, we would never screen for diabetes and say, well, I'm not sure what to tell you, good luck, or like, let me know if you need anything, or start glucophage, a diabetes med, and say, well, start the glucophage, if it doesn't work, let me know, call me, or just start it and hope for the best. That would never happen. We would never ever do that. It just would be considered not the standard of care. For mental health, both in OB and beyond, settings beyond, we sort of see that, right? Someone starts an antidepressant, they hope for the best, they give them a number for therapy, they hope for the best. And so what we've also worked to do beyond sort of the MCPAP for Moms model is we've worked to create, we've done this in collaboration with ACOG, American College of OBGYN, we've worked to create models to really have mental health care be truly part of OB care, just like diabetes. So it's screened, it's followed up, and it's managed until treatment remission, just like we would for diabetes, right? And so we've worked to create additional resources because there's this, I think, really seductive fantasy that we'll either screen and then we're all set because we've done a screen, or that we'll screen and start a med and we're all set, or screen and give a number for therapy and we're all set. And that's just absolutely not true. We would never accept that kind of standard for any other illnesses. We shouldn't accept it for mental health. So we've worked to create these models. They're all actually freely available on ACOG's website and also our website, to really have this stuff be integrated into OB care, so it's truly part of the workflow and it's addressed just like any other medical challenge.
Like when we're talking about the workflow, I know that like we've been focusing on the like the direct care and clinician and patient relationship. There's been a little bit of talk about families, but there's also other roles such as care managers and navigators, players at the payer side of things and the provider side of things. And Alicia Harris, who's a program manager at Centene Corporation, she brought up a really good question that I'm curious about too. Is the basically she was asking that, does your organization take consult calls from case managers within the managed care component or the insurance component? So maybe that invites a way to talk about also like that relationship with managed care and the payer relationship as well, in addition to the clinical aspects we've been focusing on.
Yes, so we do. So, I mean, there's now 29 of these programs across the country, and they all differ. So it's one size fits none, in my experience, when it comes to implementation. Like what works in Massachusetts, every state has its own values, its own region, its different populations. So they all are implemented very differently, as they should be. And so for us, we at our program in Massachusetts will provide consultation for anyone who's serving the goal of us is to really be building capacity at the medical home. So ours is based on a medical model. In other states across the country, it's more of a community-based model. So it really can differ, but I think all of the programs I believe would take a call from like a care manager working in a medical setting for sure. I think when we think about, to answer your question, Chris, about the reimbursement, it's a big challenge. There's challenges with like lack of parity between mental health care and physical health care is one challenge. One of the challenges with OB care is that it has a bundled payment. And so there is not necessarily a financial incentive to address mental health care. And OBs in my experience, what I hear from OBs is that they're doing this because it's the right thing to do and they want to help. They're not even able to submit necessarily a bill for it or get paid for any of the work that they're doing because of the way that OB reimbursement is structured, which is typically based on a bundled payment. And, I have to say, whenever people ask me when we do implementation, what do we do about how to get reimbursed for this? That is the most challenging question we get. There is no simple answer to that. We could have a whole session just on reimbursement, but it's a big challenge. And yeah, I'll stop there because we could keep going on about it, but that is a major challenge. So it's a really good question.
Understood. And thank you, Alicia, for keeping the good questions coming. It kind of leads into another question that we have, because just overall, we know challenges with regards to reimbursement for all sorts of issues. And one of those is technology. But reimbursement question aside, curious about your thoughts on the role that technology can play in assisting in this relationship as well.
So I think technology can and should have a key role in this. One of the things one piece when we think about mental health care in general, including perinatal mental health care, there will never be enough humans to treat all the individuals that need someone, to treat and support the individuals who need treatment and support. It won't happen in any of our lifetimes. There just isn't enough. I was actually on the phone. I recently had a meeting with someone who was running a very large medical center, and they had 3,000 people on their waiting list for a mental health appointment. 3,000 people. And this person was like, we can't solve this problem with humans, right? It's just it's not possible, even if we train people. So technology can really be helpful. I think when we think about technology, what I worry about is there's sometimes, I think, a fantasy that will, the therapist can be, done all through AI, or we can sort of replace a human with an app. I don't think that's possible. The way I see technology, and it gets back to the question that we was asked earlier about, co-located care. I think we need a stepped care approach whereby, so for example, if somebody has milder illness, it could be that they start off with an app with a coach to sort of help check in on the app. I think that the apps and technology can be a way to extend a human relationship. And so the more comes out of that human relationship, because it's not going to be possible for every therapist to be, discussing all the things that could be done through an app, right? That'd be wonderful, but just like having a co-located mental health clinician, not possible. So if technology can be used as a way to extend an existing relationship with an OB practice, with a perinatal care professional, with a therapist, that can be one step, right? The next step could be then they actually see someone in person, ongoing. If that isn't effective, then you can have, pharmacotherapy, then you can, then you have increasing, intensity of care. So that's the role that I see for technology. I would say the other thing I think where there's an opportunity for technology is for monitoring. Ideally, we're providing measurement-based care, right? Going back to diabetes as a parallel, we check people's blood sugar. And if the blood sugar's not under control, we change the medicine. We should do the same for mental health, right? If their symptoms aren't stable or they're not improved and they're not in remission, then we should be adjusting the treatment and support, whether that's adjusting what therapy they're providing, whether that's adjusting their medication dose. We should have a similar approach where we have measurement-based care and we're adjusting our treatment and support in response to that. And technology, I think, has a huge role for that. And ideally, there's a bi-directional sort of information flow between the patients, the provider serving them, and it can extend and amplify that relationship that they have with the provider. That's the role that I see for technology.
Love that frame up. And, we are Wobot Health. We are develop a mental health app, but we're not walking into organizations and saying one app to rule them all, because you frame it up as part of a relationship where there's conversation about the application and what happens there, but it's not looked at as the end all be all or replacement. And Athena, I'm blabbering on too much. I would really love to hear your thoughts on that same concept as well, especially given some of our work in that area.
Nancy, I love your frame up there for stepped care. And there's some international models that implement stepped care according to their mental health guidelines in a way that's really quite, feels practical and implementable. I wonder, given your expertise in the perinatal and postpartum space and your success with MCAP so far, what would be next steps to say, how do we bring stepped care to postpartum mental health care? What would be kind of the brick by brick layout you might envision to help both providers and patients and their families adapt to what it would be to make that a success?
So I think that I do a lot of work with implementations. I would say that we really need to think and have a structured approach for example, going into a healthcare system and thinking, okay, let's look at what you have now and how can we, leverage what you have and build on it to create a step care model within a healthcare system, and actually having an approach for that. So for example, you go to a practice and you look at what are they doing right now? Are they meeting the standards of care? And if they're not, which most of them aren't, I can tell you that, like none of them are, because it's really hard. Otherwise we probably would, we wouldn't need this podcast. So we, looking at, are they meeting the standards of care, and then creating a step care system that helps them get there. And really thinking about how that gets fit into the workflow. And it includes, for example, if someone, scores this, a certain score on, the depression screen, we use the Edinburgh Personal Depression Scale often, or the PHQ-9, if they score that, then the first step would be, okay, then, maybe they are, the clinician speaks with them, they're referred and they start an app, and maybe there's another additional treatment. So they really sort of have that step care approach. It's actually integrated into the workflow. And with that, you have measurement-based care. And I believe what's also needed is a navigator to be able to help patients navigate that healthcare system. We just did a qualitative study, which we asked the question about, how do we integrate? We were asking a lot about peer supports, and what we heard from so many people that we interviewed in this particular study was that people want someone to help broker these relationships. It is extraordinarily challenging to figure out the healthcare system. And it's even harder if you're in a position where you have, barriers due to health insurance or due to, socioeconomic situation or what have you. So having a step care approach, having an implementation process that includes a step care approach that thinks about increasing intensity based on the need, which is quantified based on like a screening tool and, supplemented by an assessment. And then having someone to help that individual, navigate all those different things, right? And having that be a systematic approach that's implemented in healthcare systems. And that approach goes to a system, assesses what they're doing, and helps implement that in a really proactive way where there's infrastructure to look at it and implement that. I think that there's a fantasy that if we create these things that people will use them. I'm always amazed, and I'm sure you see this at Rollbaut, how extraordinarily challenging it is for people to actually integrate interventions into the workflow of their practice. And so I think that there's a need for a proactive approach for that.
I totally agree. I really appreciate what you're saying. Again, that's that vibe of meeting people where they're at, right? People have the heart and the willingness to do it. And that's often why these providers and these, are in these roles, but also having the ability to listen. What are you guys doing right now? How's the screening process going right now? Exactly. How can we plus one to that equation to what would be helpful next? And working together to not ignore what the reality of the administrative burden, but join together in making it a success.
Right. And I'd say two things. I want to amplify what you just said. One is going back to that one size fits none, needs to be tailored for different settings. And there has to be a proactive tailoring process. And the other thing is not having the perfect be the enemy of the good. If you go in and you're like, I want to do all these 5,000 things, and maybe well, we can't do any of it, then they shut down. So you do what's feasible for that particular place. And it may not be as much as you want, but it's going to be better than what they were doing before that. And that's okay, because as long as there's some progress. And I think focusing on it that way, because I think when we are focusing on the goal, I think, like you said, meeting them where they're at is a really important piece of it when we think about implementation.
Now, when we have these conversations about the practical reality, not letting perfect be the enemy of good and things like that, it just makes me think about the journey that you may have had starting MCPAP in 2016 and the learnings along the way, the types of stumbling blocks that maybe if you share, and you've been able to take this to organizational and political levels, what are some of the learnings along that journey among getting leaders and peers engaged enough to make these programs a success and grow?
Three things come to mind. One thing that comes to mind is the power of relationships. I think that it's all about relationships. I think that in my experience, people often ask me, oh, how did you get this thing to be all across the country? I didn't get this thing to be all across the country. I hung out with people and I made friends with people and I developed relationships with people that got this thing across the country. And it's all about those relationships and really building on those. And when we think about those relationships, the second piece is like, I love Ayanna Presley's quote, which she says, the people closest to the pain should be closest to the power. And what I have seen is when we work with advocates with lived expertise, really centering those who are closest to the pain is absolutely critical, because they're the ones who really know what's needed, and they're the ones that are going to have the passion to go out there and to go out on the hill, whether it's at the state level or at the federal level, and make change. I've been really amazed at how much people's personal passion can make a difference. And I think that is actually what, in my experience, is what impacts policy. I see policy driven by personal stories and driven by affect more so than data. That's just what I sort of often see. The data matters. I'm a scientist. I love data. However, the data without the stories is not, I don't think it's as powerful. So I think you need to combine data with lived expertise and lived experience and centering those stories, particularly among people who've been marginalized whose voices might need to be amplified. And I would say the third piece when we think about it, so it's about, the lived expertise, the relationships, and I'd say the third piece is about really being flexible in how the thinking and thinking about how can you scale things by not having the goal be unrealistic, like really meeting people where they're at. Like when we think about MCPAP for moms, is it ideal? Is it ideal that OBs are managing bipolar disorder? Absolutely not. However, that is a lot better than somebody not getting treatment for 6 months that could develop postpartum psychosis and get really ill. So thinking about, it's not ideal, but it's progress, and it's better than what we can have without it. I would say those are sort of the three key learnings that I see in thinking about change and how to affect sort of systems level change.
So that's tremendous. And also it brings home some really powerful points, especially to people that over rely on charts and tables and things like that they think have an impact. Well, that's missing part of the story, not only in terms of communication, but also in terms of understanding. Because as like if someone is more purely on that data side and forgets about what's happening on what's fed those spreadsheets and what's created those scenarios, then they start losing vital context about the quality of their decisions to begin with. So it's not only important the stories and that just personal understanding and relationship aspect, not important just for the communication aspect, but to know that you're doing your best work in data as well.
Yeah, and I think it speaks to the importance of like qualitative data, which is often stories, right? Like we would never have developed our program or done any of the work we've done if we had just looked at quantitative data. We would never have. We wouldn't have gotten the story. It's the combination of, we did focus groups, we talked to people, and we were developing things in partnership with the people we were aiming to serve. Like I didn't sit there and think, I'm going to go give the OBs what I think they need. I collaborated. My dear colleague, Tiffany Moore-Simons, we developed the stuff together. And so we were doing it in partnership with each other. And that gets back to the importance of those relationships, because we were hearing from people about what they needed. Then we would develop something, we'd get more feedback, and we would sort of keep doing that process. I think that part's really critical as well.
And Nancy, I would say too, that beautiful cycle that you just explained too, not only invites voices from people whose voices have been traditionally not heard, but allows them to see how their input comes to life. Mm-hmm. And it feeds the cycle back in a beautiful way for that to be ongoing. That addresses that health, helps address that health equity piece and brings it into this evergreen process of let's build the fabric of our communities together with your voice and mine. Let's see how we can ride this out. So thanks for sharing the importance of that heart at the center of your cycle. I do love that.
And it does tie a knot as well to something that you had brought up earlier, Athena, which was around, hey, the importance of having this conversation is establishing these types of relationships. I think that anybody who watches this and anybody who's on with us live right now, look at the other attendees or whatever, go ahead and follow them and connect, because these are the folks that are going to be able to provide that support as you try to drive this change. But speaking of change, there's the change that you've worked for so hard over these past years, and then there's the change that you can act with a magic wand. We give each of our guests a magic wand that's able to change one thing about how healthcare is delivered, or the healthcare system in general. So with that power and where we are right now, what would you do with that magic wand?
I would, if I had a magic wand, I would wave it so that our healthcare system was more proactive and less reactive. So our healthcare systems are, we are like from a psychiatric standpoint, right? We're pouring money into extra hospital beds. We have kids in the ER waiting a really long time to even be seen. They're waiting on units. We have this need. And so we are pouring money into sort of reacting to these crises. And what I would like to see us do is change healthcare in general so that we are, from the start, focusing on building resilient and healthy families. And so I'll just say a couple things. I'll say two things about it. One piece is that I think we need to change the sort of healthcare piece in general so it's more proactive and less reactive. And then also when we think about the timeline. So I was talking to somebody recently and they said, Nancy, how are we going to solve this crisis, right? We just talked about how there'll never be enough mental health providers to see the people that need one. I think the best chance that we have of addressing the crisis is by focusing on promoting resilient families. And to do that, we have to start in utero. So as soon as somebody's, pregnant, we think, how can we bolster this family and give them the supports that they need so that we're not perpetuating transgenerational trauma, right? And that they can grow up and be healthy and they may not need mental health care later on. Some of these illnesses, I acknowledge, they're biologic and they're gonna happen regardless, for sure. However, we can mitigate the risk of a lot of them and potentially prevent a lot if we really focus on promoting resilient families and focusing on that sort of really early relationship between the parent and the child, and doing that from day one and even before they're born. And we also need to, so that's from a sort of a clinical standpoint, and then thinking, if someone sees their primary care, how can we think about, okay, rather than thinking about, okay, what's your medical problems, how are we going to address those, thinking about, okay, how can we actually help this person be well so that they don't need that care later on, right? And I would say the other piece to parallel that is we also need policies that are less reactive and more proactive, right? We have so many policies in our country that perpetuate inequities, that drive negative outcomes, and then we react to them. So for example, if there's a school shooting, then they pour money into mental health, increasing access to mental health care. And we have a lot of restrictive policies right now around reproductive rights. We know that these drive negative outcomes. We know that they're going to increase maternal mortality. And then we have to react to them and pour money into reacting to those policies. So I'd love to see us, from a healthcare system standpoint, change so that we're thinking proactively, bolstering resilient families, and that we have political determinants of health and policies that actually promote healthy outcomes for families and for children.
That's a extremely powerful thought, and I really look forward to you waving that wand, even though the magic wand, I think it's waving, but it's just very slow right now, and we'll have to be patient towards progress to that. And it reminds me of a quote from Oleg Tarkovsky, who is a leader at Care First Maryland, which is the best treatment is no treatment. And while that might sound a little bit hairy, on the offset, when you think about it, the best treatment is creating the conditions in which the medical part is not needed.
Exactly.
Well, Nancy, this has been an absolute blast. Athena, thank you for jumping on here as well. There's going to be people I can already tell in the comments that are excited to follow your work and keep updated on what MCPAP is doing and other efforts, things that you're leading. What's the best place where people can keep in touch with the things that are related to the work that you're doing?
Yeah, so I'm on LinkedIn, so that's a place where people can outreach. And also, we have our website. It's Lifeline for Moms, or actually, larger center, Lifeline for Families. There's, a way to reach me there. And, I also have emails, so happy to connect with people.
Well, been an absolute pleasure. We're going to close out next, but Athena, honestly, like you shared so much, and I wanted to hear any final thoughts from you, or maybe what you might do with that magic wand.
I concur. I think, Nancy, it's been fantastic to hear your journey. Thank you for your spirit and your championship. It's so fantastic to be part of and hear about these kind of things that go on. And the other part that I want to give you credit for impacting too is the providers as well, because it can overwhelm providers and can feed burnout. And then families are less likely to get the help they need if providers are like, I don't know what to do, and it's very stressful for me, and it can be very overwhelming, even when they have that heart and the desire to help people. So just kudos to you too, from that provider point of view, that we're also helping those folks do their job and feel fulfilled in their roles without that sense of being overwhelmed about mental health, because it can be if you're not sure where to send your patients. I would just join you in the waving of your wand in that regard.
Well, with that, we really want you to take inspiration from the types of people who are saying no to the status quo in healthcare. If Nancy's story has inspired you, then I encourage you to take a look at our episode with Dr. Thomas Insel, who is the former head of the NIMH, National Institute for Mental Health. And you can find that by Googling Beyond the Status Quo Insel. So thank you very much, folks, and we will see you next time.